So hypertension is actually one of the most common reasons for office visits in the United States, as well as for the prescription of drugs. And about half of the adults who have hypertension, they're not adequately controlled. So you can understand the magnitude of the disease. Normal blood pressure in the United States, we have 130/80 is systolic hypertension, or what we call the upper and the lower, and diastolic, which is the lower, is 80. The Europeans are slightly different. They have the cutoff as 140/90. So in usual adults, the normal blood pressure is 130/80, and then we have the different types, including the stage 1, stage 2, and so on. So our next question would be, how do we diagnose the hypertension? So it's integration of repeated blood pressure measurements, both in and outside the clinic or the hospital setting. And then we look at those numbers, and then based on that, we can say whether the patient has hypertension or not. Now, there are certain definitions that we follow. Some say during the daytime it's 130/80, and then according to the strict definition, if you look at the blood pressures at night, it has to be 110/65. But most of the time, because at night, usually when you're sleeping, your nervous system is not as active as it is, so that's why we have a lower number. But again, for practical purposes, the morning or the daytime blood pressure readings, which is 130/80, is the one that we usually follow. Now, there are different types of hypertension, and you might have come across. One is the white coat hypertension. Have anyone of you heard of that? Yeah. And then there is another, what we call the masked hypertension. So anyone has an idea what is white coat hypertension?
That's when you're in the clinic and you can take your blood pressure and your it goes up because you're in the clinic with a doctor.
Absolutely. As the name signifies, that's why we're not wearing white coats. Yeah. So, if there are consistently increased office readings that do not meet the diagnostic criteria, these are called the white coat hypertension. In clinic, you have increased blood pressure readings, but out of the clinic, you do not have, and you do not meet the diagnostic criteria. These are called white coat hypertension, and it's important because these are the patients that, over a period of years, can develop hypertension. So these patients have to be followed annually. And the other concept that sometimes we talk about is the masked hypertension. I've heard of that. So it's actually the opposite. So that when you're in clinic, you do not have blood pressure that meets the diagnostic criteria, but when you're out of the clinic, then it does. So in these cases, these patients are treated as if they do have hypertension. So these are the two types. Now, when a patient comes into the hospital, or I would say to the clinic, usually we check the blood pressure, and we can do two different ways. One is the oscillatory, where we use the stethoscope, and the other is the oscillometric, where there's the cuff, and then automatically checks your blood pressure. And especially when the patient comes in for the first time, there is some anxiety. There is what we call the concept of white coat. So the oscillometric is the one that takes the blood pressure a couple of times when the patient is in the room and there is nobody around. And you take the blood pressure and then you take an average of that. So when you're in office-based, it's the best way, even at home, is that you tell the patient to sit in a quiet room for at least 5 minutes. So you do not want to take a blood pressure as soon as the patient comes in, because if they were running late, gosh, Marshfield, there's not much traffic, but in bigger cities, if you're stuck in traffic or a little anxious for whatever reason, it's not. So you have to sit in the room for 5 minutes or so, and then you take the blood pressure. When you do that, you have to make sure, at least during the first visit, you take blood pressure in both the arms. And I'll come to that, what's the significance of that. And then you will repeat the blood pressure again. When you're taking the blood pressure, you have to make sure that the patient is properly positioned. And when I mean the position is, they have to have their back straight, supported. You have to make sure that the legs are uncrossed. Yep, and you then take the blood pressure. The reason that you take blood pressure in both the arms is usually there's not much of a change in the reading between the two arms. But if there is a change of more than 15 millimeters, then at that point you might think of some other anatomical causes of that. One is if there is a stenosis of the vessel that's causing that, or some what we call the peripheral arterial disease. Similar, concept applies to when you're at home. Now, in addition to that, I'm going to talk about ambulatory blood pressure monitoring. So this is, you're doing it at clinic. Have you heard of the ambulatory blood pressure monitoring? No. So this is, that's being now very commonly used, especially in the bigger centers, not in the smaller, even I would say in the smaller centers as well, is where you have a machine that constantly measures your blood pressure. Now, what do you think, could be the different reasons that we use it?
People that fluctuate a lot.
Perfect,
Yeah.
absolutely. That's a very good point. The patients who have what we call the episodic hypertension, those are the ones.
Or just had a heart attack or something? Do you
Not really, but patients who do have episodic hypertension, but that can kind of let us know about one of the rare diseases that can cause that. Also, if you want to see how is the response to your blood pressure medications, if the patient's blood pressure is not being controlled, you want to see what's the reason for that. Other things are, you have to make sure the patient has a resistant hypertension, that you have been using 3-4 medications and the blood pressure is still not adequately controlled. You want to see that. And also, if there is a discrepancy between the office readings and the home readings. So at that point, ambulatory, and this is actually the gold standard. But because of the logistical issues, cost issues, insurance issues, we want to not be able to do as much as we can. The third thing for us is when you check the blood pressure at home. And the ambulatory blood pressure, which is the constant, and the home blood pressure are the ones that correlate very well to the studies that have shown with the end organ damage as well as the mortality. So if we are checking blood pressures at home, adequately with the proper technique, and also the ambulatory, those are kind of the ones that are usually the way to go. And when you are doing blood pressure checks at home, then make sure you have the appropriate training as well as you have the right equipment for that, which means that it has to be calibrated. And the way, again, you do that is you're sitting in a quiet room for 5 minutes with your back and arm support, and then your legs again are uncrossed, and then you check blood pressures. When you're checking blood pressures at home, you do it at least 10 to 12 times over a period of 1 week. And you do it at different times of the day. Sometimes you'll do it in the morning, sometimes in the evening, and then you write it down. Because that way you'll have a good sense when you come in what kind of readings do we have. So next I'm going to talk about is what we call the primary hypertension or the essential hypertension, and then the secondary hypertension. So with primary hypertension or essential hypertension, you're not exactly sure what exactly is the cause. There's so many things that have played a role, with age being one of them. As you know, as you grow older, you get more chances of becoming hypertension. There are also some genetic factors. Race comes into play an important role. Your physical activity, your dietary habits, salt intake, all play a role. So family history is very important. If you have a parent, one or two parents that have hypertension, then your chances of becoming hypertensive is about 20 to 30% higher as compared to the other. Similarly, certain races have more severe hypertension, like African Americans. They have more severe and more what we call end organ damage as opposed to Caucasians. Also, your salt intake, if it's more than 3 grams, you're more prone to the hypertension. Physical activity is another role. And then also what we call the decrease, if you have kidney disease, or decreased number of nephrons, which are part of the kidneys. If you have less of those, then of course your chances of becoming hypertension are higher. The second is what we call the secondary hypertension, and that again, different medicines or other treatments that we are using can cause it, especially the oral contraceptive pills who have more of the estrogen. They can, or those people or patients are at increased risk of hypertension. Again, if you're using a lot of NSAIDs, non-steroidal anti-inflammatory drugs for an extended period of time, those patients are at increased risk. Some of the antidepressants can cause increased hypertension. Some of the what we call the immunosuppressant medications, some of the chemo medications that we're using can cause increased risk of hypertension. So these were, some of the things about hypertension. Now, what are the complications of hypertension? So, can you name or anything that comes into your mind? cerebral hemorrhages or brain bleed, heart failure, because when you have hypertension, your left ventricle or the chamber of the heart that pushes the blood, it becomes, over a period of time, becomes more enlarged because your vessels are stiff. It has to work against more resistance. So the pumping capacity over a period of time, it's not able to squeeze as much blood, and then it gradually gets bigger. And when it does happen, what happens is there is this backflow of the blood, or you have fluid buildup in the lungs, and that can cause symptoms of heart failure, where you have swelling of your legs, there's fluid in the lungs, you get more short of breath. So these are all some of the complications of hypertension. And hypertension, in addition, to the other risk factors for heart disease, it's one of the most important modifiable factors. There are other factors that are, but this is one of the most important modifiable risk factor for heart disease. Now, when do we screen the patients for blood pressure? And at what intervals do we need to? So anyone, the guidelines from the American College of Cardiology is that anyone who is 18 years or older should be screened for it, at least, on an annual basis. But for people who are greater than 18 years of age, and also their blood pressure is between 120 and 129, the systolic blood pressure, and have some of the risk factors as well, like obesity, family history, then those patients need to be screened twice a year to make sure, because these patients have additional risk factors, so that's why we screen them twice a year. Now, as I said, the diagnosis of hypertension is an integration of blood pressure readings both in and out. So if you're taking the blood pressure at home, and if your readings are systolics or the upper 130 and diastolic 80 or higher, then you do have hypertension. Again, as I mentioned, you have to have these readings 10 to 12 times a week over a period of, like different times of the day. And when you have those readings, then you have, with a good certainty, you can say that these patients have high blood pressure. Similarly, as I said, in some settings, when you have a discrepancy between the office and the home, you use the ambulatory, where there is a constant recording of the blood pressure, and it is about every 15 to 20 minutes during the day, and similarly at night, which is a little bit of discomfort, because you will see that blood pressure cuff inflating and deflating all the time. We do that. And when you are in a clinical setting, again, if you have those readings, and then you see them over a period of weeks to months, and if they're consistently high, then you're diagnosed with hypertension. Now, these are, in a setting, but there are other settings that do not have to apply these criteria. And these are called, what we call the hypertensive urgency or emergency. So if your blood pressure is, in the upper 200s, and you have what we call the evidence of end organ damage, then you do not have to have all this. It means, you have high blood pressure to that range, you have some evidence of end organ damage, then you are hypertensive regardless, so you do not have to go through all these things. Lastly, when the patient comes in, that they can present with. The most common is you might have heard, or if you have hypertension, you might have come across is headaches. Patients feel headaches. Some patients, like I have chest pain, some like shortness of breath. These are like present in different ways, but these are the most common that the patients present with. When they do come in to see us, we make sure you get a detailed history, and by history, as I meant, all the things that can contribute to that, family history, medication use, the weight, race, all these things come into play. When they do come in, we have to do certain blood tests, we have to do, if we need some urine testing, in extreme cases, if we think some imaging, as well as ultrasound of the heart, or the echo we call, not on every patient, but varying from patient to patient. And based on that, we formulate a plan, and then we kind of monitor the patient. So this in brief is about the hypertension, the different types, and the diagnosis. So if you have any questions, I'll be happy. Otherwise, Dr. Benjamin is going to talk about our second part.
I think Dr. Kiani did a wonderful job explaining what symptoms to look for, what is hypertension, and why is it important. We talked about how it can cause heart disease, and you were right when you said heart attacks and stroke. Those are the big and bad ones. But if you think about the kind of symptoms the patient has because of hypertension, you think about the headaches, you think about the palpitations, you think about just feeling generally poor, and that can cause a lot of, that can have a lot of effect on their daily life, and that can amount to a lot of distress. So they might be taking days off from work. They're not feeling so good. I have a headache today. I have palpitations. It also amounts in frequent, like Dr. Kiani said, frequent hospital visits. A lot of patients end up in the emergency room with what is called hypertensive emergencies or urgencies, and that does result in a lot of healthcare costs and burden. So it's very important to have this under check. And you guys know the bad complications. Have you experienced on your own, have you experienced symptoms that would bring you to the hospital or to the clinic? Okay. You'd be amazed how many patients actually go to the primary doctors or to the ED with these complications. And that's why it's important to not just treat those hospital or office blood pressures, but really on a daily basis, what do we do about it? Like Dr. Kiani said, blood pressure, high blood pressure can be from a lot of different causes. And if there is a particular cause, like it's a hormone problem, or it's a blood vessel problem, a kidney problem, then your doctor has to definitely be involved and treat that particular cause. Because unless you treat that, the chance of you actually feeling better and having a well-controlled blood pressure is low. So you want to definitely see a doctor about those. And then there's the essential hypertension or primary hypertension. You don't have a cause, but there's a lot of risk factors involved, and we've already talked about several of those risk factors. There are risk factors that we can change, like age. As you age, your blood vessels undergo permanent changes. They're just a little bit more stiffer with every year, and that worsens your blood pressure. So the chances of having blood pressure when you're 70 is definitely higher than when you're 40, 30, and young and active. So age is a huge one. We talked about family history. A sibling or a parent having high blood pressure gives you that risk already. And there's race. We already talked about how African Americans are more prone to blood pressure and their complications compared to other populations like Asians or Caucasians. But there's several things that we can change. What can you take a guess on what these would be?
Lose weight.
Yes.
Exercise.
Yes. And it's important to understand that those two are different. Losing weight has a lot to do with diet and exercise. Whereas exercise is what you get your heart to do, the cardio. What else? Things that we can change to manage blood pressure.
Lower your self-consumption.
Exactly, because blood pressure has so much to do with how much salt there is in the body. Diet in general. And we'll talk more about each of these things. Does smoking or alcohol have an effect?
Yes.
Yes, alcohol is a big player. Anything else that you can think about? Those are the major ones. But you also want to sit with your doctor and go through your medications. Am I on steroids? Am I taking a lot of ibuprofen, Aleve, naproxen, those kind of medications, which would automatically cause you to have, they're on all these blood pressure medications, but you don't have good control. So, are you on a steroid, a high blood a pain medication that would elevate your blood pressure? Are you on antidepressants, anxiety medications? Those can all cause changes in your blood pressure that you can easily control by switching around medications. We'll talk about that too in a second. So the big one though I want to point out is the salt intake, because like I said, blood pressure has a lot to do with salt. And kidney is very involved in that mechanism. The more salt you retain in your body, the higher the blood pressure. So what is your understanding about how much salt to consume? So if there's some things that you will remember from being here today is low salt, high on the list of things to remember. What is your understanding about how much salt you can consume in a day? How many of us read labels on food? Yeah, that's good. Yes. So if it already says in a day, if you're young and you're eating a lot of fast food, you could be consuming from anywhere from 8 to 10 or even 15 grams of salt a day. So that's definitely putting you at a very high risk. What's recommended is 1,500 milligrams, which is really low. You could be, actually 1,500 milligrams in a day is a tablespoon of salt. So it means that you're getting salt in your diet. Suppose you consume some nuts or bread or pasta or something, your chilies, you have a lot of salt already in that, and you're only allowed up to 1,500 milligrams. So one thing you can do that is definitely going to change is don't eat processed meats, fast food, and no additional salt. Like you have a chili already, no additional salt to that. Processed cured meats, high salt content, you want to cut those out. And just in general, home prep meals, you know exactly how much you're eating and how much salt there is in it. Reading labels tells you, you can in fact, if you have really a lot of trouble controlling your blood pressure, reading the label and writing them down how much salt you take in a day is a good practice. And we talked secondly about a healthy diet. There is something called a DASH diet. Anybody heard of that?
Sure. Mrs. Dash.
Yeah, but that's a totally different.
Okay.
No Mrs. Dash on our diet. But DASH diet is a particular diet that's been studied over several years, and it's been established to really control blood pressure. And what does it consist of? It says fruit, vegetables, whole grains, nuts, lean meats. So it does not allow any duck meat, any processed meat, anything high in cholesterol, those kind of things that would actually increase your risk. It's kind of common sense, but a lot of us are definitely you look at a food and you really don't you know it's tasty, so you don't look at the nutritional value of it. So there goes our DASH diet. So very important to stick to your fruits, vegetables, lean meat, whole grains, nuts are very good too, and low fat dairy, and no additional carbs on top of that. What about weight loss? Weight has so much to do with diet, more than exercise actually. You have to, you can obviously plug in your weight and your height and come up with how many calories you need in a day. I think for most women, depending on your exercise level, 2,000 calories would be an average to consume in a day at the most. So keeping a food diary and saying how much am I going over my calorie budget, if you want to call it, that really helps. So weight, as I said, is so much to do with diet than exercise. And it's been studied that if you lose a kilogram, that is 2 pounds, 1 kilogram, you bring your blood pressure number by 1. So over time, if you lose 10 pounds, you're lowering your blood pressure by 10. Does that make sense? And it's been studied, and that is, unless you have other reasons outside of like these essential hypertension, unless you have hormone problems, thyroid problems, things like that that's causing your blood pressure, weight is a huge player. Exercise. How many of us, I think some of us went to the yoga class today. It's good. And there is a recommendation on how much time to invest. I think yoga falls into the moderate exercise, and if you're able to do 1.5 to, I beg your pardon, 2.5 to 5 hours, that range in a week, if you're investing that much time and in a week and it's moderate intensity, then you lose about 4 points on your blood pressure numbers over 3 to 6 months. Suppose you're a runner or jogger, you use the elliptical, so that's a high intensity exercise. That helps you lose about 4 to 8 millimeters of blood pressure over 3 to 6 months. And if you're doing that, then you can be a little bit easy on the time to invest. It's anywhere from 1/4 to 2.5 hours in a week of investment in exercise. The other thing would be alcohol. I think a lot of us are already familiar with how alcohol affects blood pressure. It raises your blood lipids too, so that can in the long term cause atherosclerotic disease, which is heart attacks and strokes and your legs having pain when you walk because of blocked blood vessels. So we as women should bring down our alcohol consumption to 1 drink, if none, 1 drink a day. And for men, it's typically 2 and under per day. And there's a lot of other things. Like I said, stick with your doctor. Do I really have blood pressure on itself, or do I have it because I have thyroid problem, or I have adrenal problem, or is it my medications that are causing me this? Can I come off of these medications? So fewer the medications, the better. Okay, that's a lot of information. What questions do you have before we proceed to the next topic?
What does salt do to your heart?
Yes, good
Explain
question.
why you shouldn't have it.
Good question. So, when you take in salt, your kidneys actually, the mechanism is water follows salt, and salt and water activate the kidneys to it's a lot of mechanics to cause the blood pressure to go up. So salt, water, and then a lot of fluid in your body, just in your blood vessels. And over time with thickened or what's the best word for stiff blood vessels. Over time, those can just compound and cause high blood pressure. So salt actually, I think the major effect would be on the kidney, and how the kidney works is it's not able to filter out all the water. It retains all the water, so there's a lot of fluid in your blood vessels and it causes the pressure.
And with the addition to this point, besides the salt, like some of the medications that, Dr. Benjamin mentioned, they work on the same mechanism of fluid retention. And whenever you have, fluid retention, then at the same time you have high blood pressure, causes a strain on the heart, goes into heart failure. So those medicines that we talked about, there's the cause of secondary hypertension, and the similar mechanism of by retaining fluid, they also put the patient in increased risk of high blood pressure. And I wanted to add one thing, that studies have shown that if your systolic blood pressure, sort of the upper number of blood pressure, if it's above 20 millimeters, and the lower or the diastolic blood pressure more than 10, then your risk of heart disease or stroke is double. So you can imagine when going up these numbers, you're at increased risk.
What other questions? Yes.
Some things at the grocery store will list just sodium, and some will have potassium listed right under that. What is there any correlation, connection?
Yes. So both are salts.
Okay.
While sodium is not so good for your blood pressure, potassium is studied to be better.
Okay.
So it doesn't mean that you go out and consume more potassium. It just means you have to consume diets or natural foods like bananas and tomatoes that are naturally potassium sources. So I would not, unless your doctor thinks that your potassium level is low in your blood and that's the cause of your blood pressure, or you have one of these secondary causes of high blood pressure, like your adrenal gland, which is a hormone, that can cause low potassium. So unless your doctor thinks it's necessary to have these potassium supplements, you don't need them. So natural sources, I just off the top of my head, I can name bananas and tomatoes, very good sources.
Dates are another.
True.
And, when we talk about blood pressure, we're talking about, it's not that blood pressure for an 80-year-old or for a 40-year-old, has to be 130. It has to be, depends on a lot of other things as well. So we're talking 130 over 80 in general, but of course it varies from patient to patient. What are the other comorbidities they have? What's the other blood pressure medications they have? So do not take it like one, for all. It varies according to the patient, according to the different comorbidities they have. So we, in general, as a general topic, we are talking about these numbers.
So no matter what kind of blood pressure elevations you have, it's good to have these lifestyle modifications in place, like a diet and exercise and alcohol intake. But you see a doctor and these changes are not working, it's very likely that you'll need medications for this. And there's several classes of medications that your doctor might want you on, depending on what problems you have. If you have kidney disease, he may want you on one. If you have heart disease, he may want you on another medication. And like Dr. Kiani said, not everybody needs a standard below 130 blood pressure. You could be having 130 blood pressure when you sit, But then if somebody stand up and your blood pressure is down, your top number is down to 90, you should not be on blood pressure medications for the sitting blood pressure. So you definitely want to see a doctor every 3 months to make sure that you don't have side effects either from the medications or you're not being over-treated. And to try to titrate these medications to exactly your needs. If you're somebody that has kidney disease and you get put on a particular kind of medication, you'll need lab work, and you'll need to make sure that you don't have side effects from that. If you're feeling lightheaded someday, or you feel like you're going to pass out someday, you're having more and more swelling in your body, you might need those medications to be adjusted. And I think you had a question about aspirin.
I did. I was going to say, I know I've been reading that they have now recommended that an aspirin, the 81 milligrams, is not really necessary for you to take on a regular basis to help with blood pressure or heart disease or whatever.
So aspirin does not directly have a role on blood pressure. Aspirin is used for one of two reasons. A, you've had heart attacks or strokes and your doctor wants you to be on it. Or you have high blood pressure, you have other problems like diabetes, high blood lipids, and your doctor wants to prevent heart attacks, strokes, and whatnot. So you're on it for one of these two reasons, most likely. Not directly a treatment of high blood pressure.
I have another question about the blood pressure monitor. Do you think the wrist monitor is as accurate as the blood pressure cuff at home?
Usually they say, the one for the arm or to use that one as opposed to the wrist one.
And the manual is definitely better than the digital.
Oh,
Yeah.
why?
I think it's because as humans we tend to pick up the right numbers as opposed to a machine which can pick up artifacts sometimes and give you a wrong reading, and it's not always consistent, and sometimes it's not calibrated the right way. And sometimes the cuff can be too small, too big for all those reasons.
Benjamin brought a very good point, because the cuff size is very important as well. That you have to make sure that you have the cuff the appropriate size, because that will also can skew the numbers.
And are you supposed to keep your arm down or up when you're taking your blood pressure?
At the level of your heart.
At the level of your heart. So that's the way.
So you can almost like here have your
Yes.
arm down. Okay, I always assumed it had to be up.
So a perfect thing would be like that. You're sitting straight and relaxed, your legs are not crossed, they're flat on the ground, and you have your hand rested at the level of your heart and then arm rest.
Okay. Have to take it low.
No.
Okay.
It might skew your readings a little bit.
Yeah.
All right.
Thank you.
Thank you for coming.